Thank you very much for coming. You have amazing powers of concentration or maybe you spent the day at the swimming pool and only came to the lectures late in the evening, but otherwise congratulations and remaining here. So I was not expecting to give a lecture. I thought we would have a discussion. And about 5 years ago, I wrote a paper. 4 years ago, I wrote a paper called Mistakes I Have Made in My Career, or in my research career. And I explained some of the things I had got wrong. And to my great surprise, it has been the most popular paper I have ever written, because not many people write about their mistakes. Usually we write about the things that we have succeeded at. But I have to be honest and say I only wrote about those mistakes that I'm willing to admit. There will be other mistakes that I will keep secret. But essentially, and interestingly, some psychiatrists said I spent too much time talking about the patient's view. And some of the patients said I should apologize for the mistakes I had made and all the suffering that I must have caused to patients. So I was attacked on both sides. But essentially, I said that I started in psychiatry in the 1970s. And at that time, psychoanalysis was just disappearing. Was psychoanalysis ever popular in Turkey?
Not at all.
No? No.
Not much. Very recently, for the last 20 years.
It become increased or down? Really?
20 years, yeah.
Wow. How curious.
But not in institutions, I mean, only private service.
Ah, yes, very good for private practice. So, in the 1970s, we were coming to the end of the American preoccupation with psychoanalysis. In 1976, every chairman of every department of psychiatry in the United States, except one, St. Louis, was headed by a psychoanalyst. So the analysts were very dominant. And so there were analytical interpretations of schizophrenia, that it might be due to the way you brought up your children, the schizophrenogenic mother. Do you know about that? People heard of the term, the mother who induces schizophrenia in her children by inappropriate and incompatible emotions. I love you. Whoa. Excuse me. I love you very much.
Excuse us.
And I'm hitting you.
Yeah.
Oops. Hello? Yes. So this was a view that psychoanalysts suggested, which was very damaging to families, because it's very upsetting to have a child who develops schizophrenia, and then to be told by the psychiatrist or the social worker that you caused it by the way you brought up the child. So many families were very damaged by this. And there was a reaction to this, and genetics became important, and then brain imaging became important. And we started doing a lot of CT scans, CAT scans, and then MRI scans. And we thought that they showed the brains of people with schizophrenia. We did not realize that antipsychotics had an effect on changing the brain, or other drugs had an effect on changing the brain. But the view swung from the psychoanalytical view to a very biological view, that schizophrenia was a genetic brain disease. So when I was young, we did not pay very much attention to social factors. We knew that once somebody developed schizophrenia or psychosis, then social factors could cause them to relapse. And there was a lot of discussion about pathological families and high expressed emotion. If the family were very critical of the patient, saying, "You're useless, you're hopeless. Remember John, who was at school with you? He's now got a wife and 2 children and he drives a big Mercedes. And you're hopeless. You hear these voices, you don't get up in the morning." So this kind of criticism can be very damaging to patients, and they're more likely to relapse. So we were aware that social factors could make patients worse, but we did not think, nobody seemed to think that social factors could actually cause the illness. And that was the case until about 1996. And the first person really to start talking about social factors as a causal factor in schizophrenia was Jim Van Os. People will know Jim Van Os, yes? The most famous epidemiologist of schizophrenia in Europe. And
we have very contact relation with Jim Van Os, and we have also done Turk CGR study with Jim Van Os, Turkish follow-up schizophrenia study.
Yeah, so he's done a lot of studies and stolen one of your best researchers, Sinan Galos. I can't pronounce Sinan's second name. How do you pronounce Sinan's second name?
Gülöksüz.
I see, okay.
He was here last year.
Yes, so he's been
He's
been stolen away to Holland. Jim Van Os was a. I have one thing I have learned. Most of the things I have learned was from junior colleagues. I'm often said to be one of the originators of the neurodevelopmental hypothesis of schizophrenia. And in 1987, I wrote I was one of the authors of the first paper on neurodevelopment. Could schizophrenia be a neurodevelopmental disease? The other author was Sean Lewis, who then was a junior doctor, now the professor of psychiatry in Manchester. But it was his idea. He looked at lots of brain scans and said, these brain scans of people with schizophrenia, some of them show developmental abnormalities. Could schizophrenia be a developmental disorder? And I said, no, Sean, it can't. It's a progressive deteriorating disorder. And he said, no, I think it's developmental. And he kept saying this over a few months. Eventually, he convinced me, and we wrote this paper. So it was his suggestion. And then the person who started me most interested in social factors was also a junior colleague then, Jim Van Os. And in the UK, we have a huge number of people with schizophrenia who are either from the Caribbean or from Africa. And when we looked at the rates of psychosis essentially in black versus white people, we found that the rate was six times higher. And this does not seem to be a biological feature, but seems to be often to do with the process of migration. People who migrate, sometimes they are migrating from a country with war in Africa somewhere, and then they have to migrate across the Mediterranean. They may drown or they may be traumatized. Then they eventually get to England, and sometimes the population are not very friendly. I know that in Turkey you've had lots of migrants and been extremely accommodating and kind to them, but this is not the case everywhere. So the process of migration seems to increase the risk of psychosis. And Jim Van Os pointed this out. And so this was one of the first studies we started looking at social factors. And then we started looking at child abuse. And we used to think, well, people with psychosis, they say they were abused as a child, but maybe they're paranoid. Maybe it's a delusion. But we know that that's not the case, that you actually follow up children. Those who have been abused as children have an increased rate of psychosis. And so we know that social adversity of different kinds, and we know that one of the ways in which this works is by stress, and stress causes increase in dopamine. Do you know the Montreal stress test? Anybody ever done the Montreal stress test? This is a very nasty test to do. So we maybe take everybody in this row, and we say we're going to give you arithmetic, and we make it just too difficult for you to do. And then we say we're going to put the results on the wall, and the professors will do this too. And so everybody would see how you get on, how I get on, how our senior colleagues get on doing this arithmetic. So you want to do very well. But in this test, you go in a PET scan, and they say, what is 2 times 8, what is 2 and 2? It's 4, obviously. What's 3 times 5? 15, and so on. But every 4th or 5th one, when you get the right answer, they say wrong. You say 3 times 7, and you say 21, and they say wrong. And then you're on to the next one, and you're still wondering, was that wrong? I thought it was right. And then you go on, and another 5 or 6 times later, they say, what is 2 times 8? And you say 16, and they say wrong. And then by this time you're getting a bit stressed, and then they say, a voice comes on and says, are you trying? You are the worst of the whole group. Yes, you're the worst. Can you not try harder, please? So you try harder, and you get more stressed. And they say, remember, we're going to show the results. You better try harder. You're the worst in the whole group. So you try very hard. When you do this to ordinary people like us, we increase the release of dopamine in the striatum. People who are in the prodrome, who are likely to develop psychosis, they have the beginnings of psychosis, they show a higher stress response, and they release more dopamine. And people with schizophrenia, when they get stressed by a test like this, they show the highest increase in the dopamine. So people with schizophrenia are acutely sensitive to stress. And we need to think about this. Well, I don't know what happens to people here in Turkey when they are admitted to psychiatric hospital. Say they have no family. Say their mother has died, they have nowhere to go. Where do they go? A care home. And is this a lovely place? Would you like to go there? Is it in the nicest part of town, next by the beach? And they get lots of money to support them and to look after them, to avoid stress? No, in London we send them to the worst part of town, into a care home or a hostel. There may be drug abusers next door or a lot of crime, places that you and I would probably not cope with. We expect people with schizophrenia to cope. So they break down again. So from about 1996 we began realizing that social factors were much more important than we had thought before. So is schizophrenia, is psychosis a brain disease? Is it a disease? What is the pathology? There is no pathology, not that we're able to see. It's a disorder, really, or a reaction type. It's a syndrome. It's really signs and symptoms. It's not a discrete disease. But I guess the issue is asthma a lung disease? Yes, asthma is a lung disease. But what makes asthma worse? The lungs are involved in processing the air. And if you live next to a motorway, or you live in a very polluted place, your asthma will become much worse. So although it's a lung disease, the environment has a very important effect on the lung inflammation and the asthma. The brain is like this. The brain is involved in processing social information. And just like the air can be toxic, so social information can be toxic to the brain. So the social information causes the stress, which causes the increase in the dopamine. I think as we were discussing, we were discussing towards the end of my talk that schizophrenia or psychosis probably breaks up into different types. So it's a syndrome, and within this syndrome there may be different types of psychosis. So really that's the basis of what I was saying in this article. I think we ignored social factors too much and relied too much just on antipsychotics. And increasingly we've used cognitive behavior therapy. I don't know how easy, is it easy for all patients in Turkey to receive cognitive behavior therapy? Because, what is the reason? Not enough psychologists. No.
And also for psychosis, another matter, and we don't try as much on psychosis as other conditions because of the nature of the condition, I assume.
Yeah. So the cognitive behavior therapy for psychosis is quite difficult. So cognitive therapy for anxiety, for phobias, for depression is much easier, and I think psychologists prefer it. And also, people with schizophrenia don't have much money. So you, in private practice, you will make more money looking after people with anxiety disorders. But in Britain, it is every patient's right is to have antipsychotics if they wish, but also cognitive behavior therapy. And I think it makes a big difference. It's, in many ways, psychologists are better than psychiatrists at listening to their patients. At least that's my impression. So I think that has been a helpful thing. So I think the main point I was making was that there had been a sort of change in the way. I started off being very interested in psychoanalysis, and then swung away from that and got into very biological psychiatry, and then more recently have been more interested in social factors. But you can have some people who say that schizophrenia is all a brain disease, and you have some psychologists who say it's all just cognitive. And other people say there are social factors which are crucial. But in fact, it's a mixture, all of these. So we need to have a sort of integrated view of psychosis. So that's really where I have ended up. If you want to know more about, say, other mistakes that I've made, you can read, there's an article called Mistakes I've Made in My Research Career, Robin Murray in Schizophrenia Bulletin, I think about 2017 or 2018. If you Google it, I'm sure you'll find it. Anyway, I will stop at that point, and I'm happy to have a discussion or questions.
Okay, thank you so much. Ben Türkçe devam edeyim, yok İngilizce daha iyi.
Shall I continue in Turkish or English?
If there are some questions from the audience, we may take.
Thanks a lot again. So Professor Murray, both in your previous lecture and now you stressed that hypersensitivity to stress is one of the important factors in the development of psychosis, that they are more hypersensitive to stress or life events. So shall we then start vulnerable people on antidepressants? Do you think it would prevent some of the psychotic transition?
It's a very good question. And so there are these, are there prodromal clinics in Turkey?
I think so.
At risk
Yes.
mental state?
In Istanbul University there is...
No, in Izmir there is one prodrome clinic. Emre is running this unit now.
So these are clinics to which people are referred if general practitioners or other psychiatrists say this person looks as if they might be going to develop psychosis. Maybe they're students who are beginning to wonder, are the other students against me? Did I see a ghost? Did I hear something? I'm not sure if I did or not. And these prodromal clinics, maybe about out of 100 people referred to them, 20 of them, 20% will develop schizophrenia. Or psychosis, rather, sorry. And one of the questions is, what do you do with these people? Should you give them antipsychotics? Now, if you're giving them antipsychotics, you would be giving antipsychotics to 100 people, of whom only 20 would ever go psychotic. So that's probably unethical. But what about giving some of them antidepressants? Because we know that many people, before they develop psychosis, they have a depression. This is a thing that Jim Van Os talks a lot about, that the affective route into psychosis. So there has been some suggestions we should give some people antipsychotics. But of course you have to be very sure that they're not bipolar, because you might provoke them into mania. So I have only occasionally done this. We usually use psychological approaches. But I think, do you think antidepressants prevent people, but they don't prevent people suffering stress? Do you think they help you to cope with it?
They certainly help with coping with stress, but especially for someone who have low coping skills, they might benefit during stressful
Yes,
times.
some people say one of the effects of antidepressants to make you feel a bit numb. You don't,
They do, yeah.
you don't feel quite so emotionally distressed. So there is a lady in New York called Erling Mayer, and another lady called Barbara Kornblatt, who have taken people in the prodrome and given them antidepressants, and they said that this did help a proportion. The difficulty in psychiatry is knowing where does normality end and where does pathological begin. What proportion of the population should we as psychiatrists be treating? I mean, stress is a normal thing, isn't it? Some people like stress. Racing drivers, for example. Do you have a Grand Prix in Turkey? Yes. But these chaps that go in the Grand Prix, they like the stress and the risk. Or mountaineers, they like the stress. And so it would be interesting to know their polygenic risk score. You would think their polygenic risk score must be very low. So the question would be, I mean, you can't prevent stress, can you? I mean, we would like personally to avoid adverse life events and stress. We can't do that. So I think it's. I suppose if people come to us seeking help, that's one question when we should get involved. But I think we should be quite cautious. I think we in psychiatry, and I don't know in Turkey, but in Britain, general practitioners, family doctors give out antidepressants like sweeties. Your husband, you're having trouble with your husband, he's drinking too much, you've lost your job, your daughter has left to go to university, have an antidepressant. So is it the same here? Yeah. So I think psychiatrists are more cautious than family doctors, I think. Family doctors have to see so many patients. They don't have time to talk to them, so they give them antidepressants. Or worse, benzodiazepines. Fortunately, that's declined, at least in the UK. So I think in every meeting there are difficult people who ask unanswerable questions. So I think I can't give you a proper answer.
Thanks very much.
Thank you. If you have questions also, you may ask in Turkish.
Professor Murray, many thanks. I would like to ask you whether we should treat chronic schizophrenic patients with antipsychotics for a lifelong time. I mean, because in your presentation you said that a small percentage of these patients can do well without medications. So how are we to decide in which patients we should use medications and not?
So it's a wonderful question. If you go to the literature, there are thousands of papers telling you how to start antipsychotics. Until the last couple of years, there have been no papers on how to stop antipsychotics. And in Britain, what usually has happened is that the patient has the first episode, they have antipsychotics, they get better, and after they come to the outpatients, and after 3 months or 6 months, they say to the psychiatrist, I'm better now, I'd like to stop the antipsychotics. And the psychiatrist says, no, you can't stop the antipsychotics, you have to take them for life, forever. The patient gets annoyed, leaves the clinic and never comes back, throws his antipsychotics into the river and relapses, goes psychotic again. So I don't know whether you're better at this in Turkey than we have been in Britain. So there is the question that one shouldn't insist, I don't think one should ever tell patients you have to stay on antipsychotics forever. I mean, imagine if somebody tells you you have to take some medication for life. I'm sure you keep trying to see if you could manage without the medication. So I think it's better to negotiate with patients. And we've written a couple of papers with a man called Mark Horowitz about how to decrease antipsychotics. And most people decrease antipsychotics by saying you're getting 5 milligrams of risperidone, so this week we'll decrease it to 4 milligrams. Then in another week, we'll decrease it to 3 milligrams, and then to 2 milligrams, then to 1 milligram, and then to 0. The patient will relapse for sure, because it's not the milligrams that are important. Do you remember the curve called the hyperbolic curve for occupancy at D2 receptors? So you give risperidone half a milligram, it has a very little effect on D2 blockade. Then it increases very rapidly, and then after about 2 or 3 milligrams in first episode, you have saturated the D2 receptor. If you give 4, 5, 6, 8, 10 milligrams of risperidone, you're not blocking any more receptors. You're just causing side effects. But so you can decrease from, say, if somebody was on 8 milligrams, you could decrease from 8 milligrams. At 8 milligrams, you will have about 84% occupancy, 85% occupancy at the D2 receptor. If you get down to 5 milligrams, you still have 66% occupancy at receptor. Then if you get down to 4 milligrams, you have about, say, 40% occupancy, and then it rapidly falls. So the lower you go, the higher the drop in occupancy is, because of the way the curve is. So it's much easier to go from 8, 7, 6, 5, 4 than it is to go from 4, 3, 2, 1, 0. So people often relapse when they get below 2 milligrams. So you have to be very, very careful. And so if people are determined to stop, we would do this over many months. We would say you have to get to 2 milligrams, and then we will go to 1.75, and you stay on that for 2 or 3 months. And after, if you do well, we'll get to 1.5 milligrams. And if you do well, after another 3 months, we'll go to 1.25 milligrams. And at any point, if they are beginning to get symptoms again, we go back up again. So obviously in many patients they come down and then they get the symptoms back again, but you know the sort of a minimum level, so you can just increase a bit enough to stop them relapsing. In a small proportion, 20% or so, they'll manage to do without. And it's not very difficult. Ladies are better at coming off. People with good premorbid function, people who were well educated, get to university, people who have a job, people who have a partner, people with lots of positive symptoms and very few negative symptoms. All of these things would be associated with a better chance of recovery. But early onset males with lots of negative symptoms are going to be much more likely to have to continue. But it's not an exact science. In an ideal world, we would do a PET scan and we'd see, has the dopamine normalized or not? But a PET scan costs about, at least in London, about $15,000. So it's not possible, except for very rich, extraordinary rich people, to do it. Yeah. Microphone, quick. Ah, you are faster than the lady who was doing my other lecture.
Sorabilirsiniz siz.
Tamam. Thank you for the excellent talk, Professor Murray. I am a child psychiatrist, and we run an inpatient adolescent psychiatric unit where we admit young people, some of whom have the full checklist that meets the checklist for a diagnosis of schizophrenia. Our dilemma is that whether we should ever, no matter how strongly they meet the criteria for the schizophrenia, whether we should give this label to anyone under 18s. How ethical is this? This dilemma is here, but I worked with Tony James at Highfield unit for some time. We had the same dilemma there as well. Really, would it become a self-fulfilling prophecy to give this label to this person, or early diagnosis of schizophrenia instead of a wider germ like psychosis would help the person? Thank you.
It's a good question. So I think, of course, the first thing to say is that the earlier the onset, the tendency is for the outcome to be worse. And there is a recent study, came out about a month ago in one of the American journals, I think it was JAMA Psychiatry, suggesting that early onset, and I think that was what they called early onset schizophrenia, has a high rate of copy number variants. So the same proportion, something like the same proportion of people with schizophrenia as autism had copy number variants in these very early onset cases. So I think it is the case that people the earliest onset person I have seen had her onset at 11. And actually I'm still seeing her 25 years later. She's never been totally well, but she's never been in hospital, fortunately. I personally don't. I think many patients think the term schizophrenia is an insult. So I say to people that you have a liability, a susceptibility to have psychotic symptoms, what psychiatrists call psychotic symptoms. If we are lucky and you respond well to the medication, they will go away, but you may well have to, certainly, especially in young people, you may have to continue taking them for some time. I think the other thing is, of course, in adolescent, in Britain, the rates of psychosis in Britain, child psychiatrists did not used to be very interested in psychosis because they didn't see very many psychotic patients. But now with cannabis and amphetamines and ketamine, they see many more. I don't know whether that's the case here as well, but obviously one would have to address the question if it was drug-induced. I was talking to a colleague in America who said that the earliest cannabis-induced psychosis he had met was a girl of 9, who had been introduced to her family to cannabis by her parents because they used cannabis and they thought it would keep her calm and quiet and not cause any trouble, and of course she went psychotic. So my personal view is not to use the term schizophrenia unless the patients and the relatives bring it up. Of course, for some relatives, they feel it helpful. I went to Australia and I said to a group of patients, in Britain, patients don't like the term. And I said to a group of patients in Australia, I wouldn't use the term schizophrenia. They said, this is terrible. Because in Australia, you get special financial support if you get the term schizophrenia. So they all quite like the term schizophrenia because they've got more money, but that's a bit unusual. So there's no perfect answer, is there? And one has to be tactful with different patients, but we shouldn't. Does it help to cause? In what way does it help to say to a patient you have schizophrenia, especially a young person? Because the world changes. Instead of being Robin Murray, you become a schizophrenic called Robin Murray. And you don't, well, I guess young people that who are training in psychiatry, if you get ill and you're off work for 3 months and you come back to work and you get a certificate from the doctor who's looked after you, and you say you have depression, and you give it to HR, and everybody's sympathetic and says, oh, I'm very sorry you've been depressed, I hope you're feeling better. You have a certificate that says schizophrenia. Everybody says, oh, should you be practicing as a doctor? And people get alarmed. I have a lady I've looked after since 1982 when she developed hallucinations at the age of 22 as a medical student. She passed her finals. She went on to pass the medical membership while hallucinating. She said that she was writing the exam and said the voices were no use. They did not know the answers. That she's always quite an amusing lady. She became a consultant physician at a London teaching hospital. She's a very good doctor till she was 58. And she had her line manager. She'd never told anybody she'd had a diagnosis of schizophrenia or that she hallucinated. When she was 58, she had a very nice line manager. So she said to the line manager, when she had been off, she'd been hallucinating. At which point he said, you've been hallucinating, you can't be working. So he suspended her, and the hospital told her she couldn't work any longer. She's the same lady had been working for them for 15 years. But once they knew that people had said she had schizophrenia, they threw her out.
Please put your headphone. The question.
Can you hear me, sir? Thank you very much. First of all, my question is, so you're talking about hypersensitivity in neurodevelopmental process of schizophrenia. In the developmental process, if there's schizophrenia involved, were you talking about a hypersensitivity concerning stress development under stable conditions, or are you talking about a hypersensitivity under changing conditions of stress? So if there is no triggering effect under the conditions are totally normal, let's say, but then these persons are going through a very intense stress, let's say, under normal conditions, or as you said a moment ago, there might be very exciting situations that people go through. So are these people hypersensitive to this stress situation under normal conditions, or maybe also under stressing conditions or abnormal conditions, let's say? So this is my question.
So it's a good question. I think it's a matter of degree that people may be able to cope with small stress, but they are just less able to cope with quite major stresses that many of us, we would be upset and we might get anxious, but we wouldn't actually start hearing voices. So I think if you have the predisposition, you are more sensitive, particularly to social difficulties. And I always wonder, say you take a young boy of 8 who his mother had schizophrenia, so he has the vulnerability, and he's not very good at school, and he's not very good with other children. But if he has a wonderful teacher, and the teacher makes him feel at ease in the class, and he's very lucky and the other boys are very nice to him, even though he can't play football very well, they still allow him to play. And so he doesn't feel alienated from the other children, and the teacher maximizes his cognition. Expect. Perhaps he's very handsome by accident, and at age 13, a beautiful blonde girl, for some reason, falls in love with him. She is very extroverted and sociable. She protects him from social adversity and gives him lots of support. Do an experiment. I think it's a question of the extent of stress. You might be able to cope with stress very well. Be able to, and somebody with the vulnerability to schizophrenia would be the least likely. But if any of you have little sisters, nobody is volunteering their sister. No, it's ladies don't like this idea. Well, look, take it around the other way. A girl who is susceptible to schizophrenia, could you get your little brother to look after her and prevent other children bullying her and prevent her having stress?